We'll go ahead and get started. I'm joined today with Ginny Healthcare Help. So Ginny is going to be talking today about all the different ways to navigate through the quagmire that has become the American health industry, and particularly insurance. So tell us a little bit about what your company does and how you help people get through this mess of Medicare and all these different insurance companies.
Well, since 2015, the whole pretty much the whole the whole landscape of healthcare has changed. Obamacare, which was a humongous book, had a few things that were takeaways from them that has changed the evolution of what we call healthcare today. One of the biggest things in there was a paragraph in there that read that 40% of what the provider takes in is all that they're allowed to charge us, the consumer, for healthcare. Well, the impetus behind this particular legislation was to lower the administrative costs of healthcare. Instead, it's done just the opposite. What it has done, it has turned all of our regular plans into more catastrophic healthcare plans on a general across the board. We're paying more for healthcare. Why? Because the more that we pay, the more they can spend on their administrative costs.
We're paying more for healthcare, and the healthcare has changed.
Well, and that was exactly, and that's what I was going to get to next. So, in order to cut back on their administrative costs, you see a lot less doctors. You have seen professions that have taken off. Your nurse practitioners, your physician's assistant, those are the people that you see. Why? Because it costs less to hire those people than it does to do the MD. So more often than not, you're paying to see people that are not doctors. But your insurance is being charged the same amount. The providers are also getting very creative in costs. So what does that mean? So now you get a wellness visit instead of a physical. What's the difference between a wellness visit and a physical? Well, in a physical, your labs are included. In your wellness visit, you're going to pay extra for your labs. They've even come up with more codes. For example, colonoscopies this year and mammograms as of 2 years ago have two different codes. You have a preventative and you have a diagnostic. Now, by definition, the preventative means you have no symptoms. However, in many cases, you're finding these providers are billing at diagnostic codes. Why? Because if they can collect money from you, it helps their bottom line for the 40% administrative costs they're allowed to carry. So, what I put out to you is if you receive a bill for either a mammogram or a colonoscopy, call the number on the back of the bill. Why? Because you want to know if it's been coded correctly. My husband, who is at risk, both his father and his uncle died of colon cancer. I finally talked him into getting a colonoscopy this year. We got a bill. He has no symptoms. Now, oftentimes you can't even talk to the people in billing. That's the norm. However, talk to the machine. This is exactly what I did.
I have a lot of fun talking to the robots that love healthcare, because it takes a lot of effort just to even get a human on the phone, and you can have some fun with it. There's a couple of people on TikTok that they record themselves talking to the insurance companies. It's quite entertaining. I would recommend it.
But when it comes to your bill, again, you have to be proactive. So again, if you get a bill for something that you believe is preventative and you're getting a bill for it, call them up and say, look, this is my invoice number. I think you've recoded this wrong. It may take 2 phone calls, but guess what? I no longer get that bill from my husband. We'll give it a shot.
I like the phrase, it's not a design, it's a feature. And the insurance companies have made it so that you have to fight to get things like this overturned. They know that 9 out of 10 people are not going to call. They're not going to sit there for 45 minutes on hold and get through this and talk to this and ask to speak to a manager.
Correct.
And they know that they're going to make money because nobody has the fight to do that, because who has 2 hours to fight with their insurance company?
Or even to wait on hold.
Right. You have to wait on hold for an hour to get somebody on the phone, and they're only open 8 to 5, and
odds are they can't answer the question, or they need to talk to somebody else because you're talking to a gatekeeper and not somebody that can make it.
There's nothing more frustrating than waiting an hour to talk to somebody, and then that person puts you right back on hold, and then you're on hold for another hour. I would recommend, if you're not on anti-hypertensive medication before you call your insurance company, I would recommend getting on a good beta blocker or something.
I recommend just having your speaker feature on your phone and walk about your business doing whatever it is that you need to do around your house. That's what I do. I just put it on speaker.
So, Ginny, I meant to start with this, but I kind of got it's fun talking to you because having worked in the healthcare industry is we see the mess for what it is. And there's no way to just, when you're talking to somebody who's non-medical, to just dip your toes into the insurance. There's no simple route in. Everything is so interconnected, and it's politics, it's medicine, it's science, it's psychology, it's bureaucracy, it's everything is just melded into one ugly mess. And it's hard to just say, well, let's start here and now I understand insurance. It's very complicated. So I was hoping to just kind of take a step back and just kind of go through a few different, just simple basic things that if somebody's listening to this, like, I don't know the difference between a copay or a co-insurance. What I wanted to talk about is just some key words to understand. And I think the most important question everybody asks is, what is this going to cost me? At the end of the day, what is it going to cost me to live the life I want to live and be healthy? So I was hoping you could just kind of give like some 101.
Well, the basic, if you want to go down to the complete roots of everything, you need to know what your network is. Network is key to everything across the board. So when you get your explanation of benefits, when you get the beginning of the year, the changes that are going to be happening to your health plan moving forward, one of the things that you have to know inside out and backwards is, who is my network? You can go to a primary care doctor and know that they're in the network because you look them up. However, if the primary care doctor says, oh, I need you to get some lab work, there's a lab down the hall, you cannot assume, first of all, that lab is in your network. Because oftentimes they're not, just because they're housed in the same building. There was some legislation that was passed that addresses a lot of this today. It's called the No Surprise Act. It was enacted in January of this year. Basically, what that legislature is to protect you from getting out of network charges, because again, they have become insurmountable and they're hard to argue because all they can say is, well, we're not in your network, so therefore this is what you have to pay.
And you would hear stories of ridiculous things that are out of network, where you would go to a hospital and that doctor was in network, but the surgeon that you saw was out of network.
Yes, that's been around since day one, because that's that loophole.
And you'd say, well, I'm in network with university. I went to university. Why is this out of network? And you say, well, it's more complicated than that.
The No Surprise Act in the first quarter of this year saved over $2 million in charges and out of network. And the way the No Surprise Act is, and again, I'm not going to get into it. Low. That was only for the first quarter.
Okay.
So that's the first 3 months of the year.
Gotcha.
So we haven't gotten through the second quarter quote or statistics yet, but as of the first quarter. So look it up, because basically what that tells you is if you walk up to that lab that's in the same building as your primary care doctor, they have to tell you that they are out of network. They have to give you a list of in-network providers that you can go to, as opposed to.
And I'll tell you, as a private practice owner, it's not an easy question to answer, am I in network with your insurance plan?
No, it's not.
And that was something that, I'm a new business owner, I'm, working physical therapy, and I found, wow, this is way more complicated than I thought. Because I signed a contract with Anthem Blue Cross and Blue Shields. And then all of a sudden, somebody calls me up and says, hey, I have Anthem Blue Cross and Blue Shields. Are you in network? Well, sure, I'm in network with Anthem. I signed that contract not knowing that, okay, there are a billion
subdivisions. You have under 65. You have Medicare Advantage. You have supplements. You have federal. Yeah. Oh, yeah.
So I think that's a good place to start. You were talking about the network. Explain us the difference between the HMO, the PPO, and the new thing, which I'm personally not a fan of, is the EPO. They're growing in popularity, but I don't like the EPOs.
I don't know who the EPO is. Who's the EPO?
The EPO, I know there's a few different ones. It's basically an HMO on steroids, where it's the exclusive provider organization, where it's you.
Well, then it's actually an HMO. Well, okay. All right. We're a little bit different. No, then I think that's what this EPO is coming into play. Here in Northeast Ohio, where we are absolutely hospital rich. There are so many hospitals within our geographic area that what happened way back in this, even as early as the 60s, is doctors formed what they call practices. When they formed a practice, they would have maybe one doctor that would be, he would be licensed under Cleveland Clinic, another one under University, another one under Summa, another one under Mercy. I mean, and they've all joined a practice. So the billing could accept anybody from any of those in hospital organizations, and that they would bill it appropriately. Well, then along came in the early 2000s, in the 1900s, the Medicare Advantage plans, which are all about the network. So we have HMOs. Now your HMO is a health maintenance organization. That is supposed to be your smallest network. You have to be a network to receive any type of benefits at all, with the exception of emergency room care. So that is an HMO.
So
However,
just to kind of back this up and I feel like my goal for today, or my role, is to just kind of translate for there's two types of listeners of this. There's the people that understand the healthcare, and then there's the consumer, the people that are trying to fight through this. So tell me if this would be a fair analogy for you. An HMO would be like somebody paying for your groceries, but saying you can only ever shop at Meijer. Is that a fair comparison? It's if you go to Giant Eagle, it's not going to pay it.
Because again, that's where I'm going with this, because we have evolved as a community with health practices that weren't true HMOs. And this is where some of the discrepancy comes into play. So you may have an Aetna and an Anthem plan, which will accept multiple hospitals because that's how it evolved. But then you will also have maybe plans like Humana and Anthem under the Medicare Advantage plan. They each have their own HMO only. That would be where they could only go to Cleveland Clinic.
Correct.
But you can have other HMOs that
that's what I'm referring to with the EPOs.
So, and I think that the EPO is just, they've gone and they've scaled down the HMO to what it was really intended to be, which was one hospital system.
So I'm gonna stick with my analogy. I'm kind of making this up on the fly, but think of it this way: there are certain types of plans where you'll say this will cover all of my rice expenses, and I can go to Giant Eagle and it'll cover my rice, and I can go to Meijer and it'll cover my rice, and I can go to Sam's Club and it'll cover my rice. There's certain plans that I can only go to this one grocery store. And then there's certain ones where it's even more muddy, where it's you can get this at Meijer and you can get salmon at Sam's Club and you can get this at that. And it's unless you understand what your network is, it's very difficult to just say, I need help, I need food. It's hard to know where to go for what service, for what product that you're looking for. And that's really what your company does.
Well,
you help understand what that is, and you help navigate that. And that's not a perfect analogy, but.
Well, the one where you can say you can get different services at different ones, or different products at different ones, that would be more of your PPO.
Right.
But even within the PPO, you have a network and you have a non-network. So there is still a preferred provider, which will give you a smaller cost share to you, as opposed to the other providers where you can still go there, but it will cost you a little bit more money.
Maybe a better example would be, okay, if you go to Sam's Club, we'll cover 80% of the cost of your food. If you go to Giant Eagle, we'll cover 60% of the cost of your food. Whereas we're still going to pay for your healthcare. We're still going to pay for your food, to keep the analogy going. But the cost is going to vary depending on where you go.
Correct.
And it makes it very difficult for the consumer to go, how do I shop? I need to eat. I need to live, I need to be healthy, I need to go to the doctor, I need medicine, but I don't know where to go. And that's really what you're a pro at navigating, is helping people understand that.
Well, especially on an annual basis, because unfortunately, these things are fluid.
Changes every year.
Just because something was in your network, just because a drug was covered, just because a doctor was in your network this year, does not mean it will be next year. Health plans are contracts. They start in January, they go through December of the same year. Whether they be, a lot of the employer ones are the same, but it's the same philosophy. It's a 12-month commitment, it's a 12-month contract. Any and all of those variables can change from one year to the next, which is why it is so important for you to review on an annual basis. This is where we come in handy. What you believe that you have this year may not be what you have next year. Or maybe for whatever reason, you got all of a sudden the doctor said that you need this expensive drug. It does not come generic. You can't find it anywhere else. So you're paying a large cost share on your current plan. Well, then you want to look to see if there's another plan out there that's got a better cost share for that particular drug. So again, there's different variables, but the reason, what is the most important of all of this is that you constantly have it reviewed.
Mm-hmm.
It doesn't have to be through me. I mean, I can do it, absolutely. But again, there's many people out there that do what I do. And what we do is we review it for you. We tell you, this is what you have to look forward to. When I review for my clients, I can give you an actual printout of what all your drugs are going to cost you at a given pharmacy for the whole next year, for what you're currently on. I can't do anything for what's anticipated. But I also have clients that call me in the middle of the year and say, look, the doctor wants to put me on this drug. Is it covered? Again, I help you explore options to find out where you can get that drug at a better cost share if it's not on your current plan. And then we review again in the fall. Fall is the time to review for the following year. You have annual enrollment for people on Medicare, starts October 15th and goes through December 7th. If you're under 65, that starts November 1st and goes through December 15th. So everybody is reviewing all at the same time. So it's very important that you get that review, because that's what's going to give you your lower cost share moving forward.
Well said. Well said. So it's funny you mentioned something in there. You use the word explore. And I was thinking of how I wanted to communicate this to everybody. And I was thinking, I'm like, Ginny's the guide. You're the person that is going to help navigate us through this jungle that has become the health insurance industry. And I meant to open with this, but I was going to say, every time I do one of these recordings, I always learn something. Well, this is our second one. So the lesson I learned from you the first time was have 2 audio recording. But I was like, so we got double audio, double video recording. So this is going to exist in one way or another. But the first one, I was trying to salvage an audio. So I was listening to what we were talking about, and I was really critical of myself. I go, man, I got really in the weeds when I was talking to her the first time. And I go, Ginny is this guide. She is this explorer. She knows how to navigate through this jungle. And I felt like I steered the conversation in the direction of, man, there's a lot of mosquitoes in this jungle. And I was just kind of complaining about how difficult it is to go through this jungle. And I go, I am wasting my time with this expert explorer, this guide, this navigator that is Ginny. Like, you know how to get through this. Nobody knows how to go through that. There's a few people in this country that actually understand how insurance works. I would say you're one of the few people that have any grasp of that. I don't think anybody really understands how it works. Or if they do, I haven't met them yet. But I really just want to really get your tips on, like, what are the biggest things that people need to know? Or what questions that you have to ask them so that they can make an informed decision? You kind of hinted at a few of these.
Well, the first one, again, we'll go back to the network. And again, that still goes back to the No Surprise Act. One of the things I want to caution you about, because I didn't get a chance to mention this, is so every time legislation comes across the board, providers respond. So in this particular situation, the response was a waiver. It's the No Surprise waiver. Don't sign it. You as a consumer, if you sign the No Surprise waiver, you are allowing this provider to charge you at out-of-network costs, and you're saying, sure, send me a bill.
Mm-hmm.
So the waiver is for the protection of the provider. So anytime, and again, you don't have to remember the name of it, but anytime you go to a new provider that you've never been to, or the same provider in a new year, say, are you part of my network? They have to disclose this. If anybody asks you to sign a waiver about being in the network, just say no. That's the simplest thing right there.
Now, I would add something to that. As a small business owner who likes to try and help people, just because a company is out of network does not necessarily mean that it is more expensive. This is part of how physical therapy works when it comes to things like cash pay is kind of all the rage in PT. So depending on your plan, and this varies widely, but let's say you have a plan with a really high deductible, meaning you have to pay $8,000 a year out of your own pocket before your insurance covers a dime. If you know you're going to only be going to physical therapy, eight visits, 10 visits, you could charge a cash pay rate at, let's say, $75 a visit, and then you could see them 10 times, and that would be $750. Compare that to if they were going to apply that to their deductible. The PT or the therapist would be charging above that rate. So you would have to pay $150 or $200, whatever the contract's for. You would have to pay these higher rates to your deductible, which if you get sick later that year and you meet your deductible, great. But if you don't think you're going to meet your deductible, it ends up being higher cost. Does that make sense?
You know,
This is
I
something we
think
deal
that, well, and again, I think that's a great option. You as a provider then wouldn't be passing over the waiver.
Correct.
Instead,
You're not even billing it.
well, again, instead, when someone asks, are you part of network, you would look it up as a responsible business owner and say, no, but you know what, we do have options.
Mm-hmm. Which is exactly
So
what we do.
again, you have to be your own best advocate and be proactive when it comes to your healthcare and what the bills are associated with it.
And I would encourage people to shop around and to look at different clinics. There's a lot of new business models that are very intriguing as far as cost saving models and different cost saving tactics. So I went to an eye doctor. I'm going to give them a shout out. What are they called? America's Best. They're up on Menor Avenue. Had great insurance, covered vision. I've been paying vision insurance. And then I went to them and I said, hey, how much is it for insurance? And they told me the price. And they said, how much is it for out of network or for cash pay? I got a year's supply of contacts, brand new glasses, brand new frames, everything. It was half the cost for me to pay out of pocket than what it would have been if I went with insurance.
Well, you know, what you're gonna find, and this is typical with a lot of your vision insurance,
Mm-hmm.
vision insurance is expensive.
Yes.
Unless you're spending about, and again, I probably have less than 50 people on vision. And I have like 600 clients. Why? Because I have often counseled them that it's easier and less expensive to go to these vision places because the cash pay is a much better rate.
And we went at our ASA meeting this past week. I learned, you may have already known this, things like cataracts is considered medical.
Right. That's right. Well, no, there's no, yeah.
There's some nuance. We go to a meeting with different
The networking group.
And this past week we had an optometrist that was talking about some of these things, and she was mentioning things like glaucoma, cataracts depending on the situation, may be covered under medical as opposed to covered under vision.
Well, you'll find the same thing with dental.
Mm-hmm.
Some of your dental things would actually be covered under medical as well.
Mm-hmm.
So if it's a medical condition, you are better off using the health insurance. The vision insurance is eyeglasses, contacts. However, she had also commented, which I always thought you needed to go to an optometrist, that they will diagnose and they will give you referrals to ophthalmologists, and that apparently people are not, since they don't need to wear glasses, they're not getting vision exams, and they're missing some health concerns that could be caught at a much earlier time.
So that kind of ties back to what we were talking about earlier about the growing nurse practitioners, the growing medicals, all these other fields, and there's positives and negatives to that, because I see a two-way street, because physical therapy is kind of in a weird spot where we're taking on different roles, but you're going to a less qualified provider compared to a physician. That doesn't mean the other provider doesn't know what they're doing. A good physical therapist would recognize, hey, this is a neurological sign. Let's say you come to me for back pain. 9 times out of 10, I'm going, oh, we just do this stretch, yada, yada, yada. Let's fix your posture and you're good. But we're also trained to know, oh no, this is a sign of a serious neurological condition. Hey, look, you have aberrant reflexes. You need to go see a neurosurgeon or a neurologist, or at least start with your PCP. So a lot of these quote unquote less qualified professions do have a lot of training and education on triaging. So you can get good results for a lower cost, assuming you go to a good provider.
Well, and again, I think there needs to be more education on that. Because you don't, we have all been taught that you always go to the doctor when there's something wrong. Now, we have also grown up with what they call specialties.
Yes.
So again, just like any doctor is good or not so good, or more thorough than other, the same thing with what we said with the specialties. I have a daughter that's got a problem with her wrist. She's been to 2 different physical therapists, And I corrected her last night. She says, no, Mom, the other one's smarter. So the first one that she went to obviously seemed to know more about what she needed and what was going on with her than the second one, who just said, well, I don't think this is working. You need to go back to your doctor. So obviously there is a level of expertise
And that's where the
at
market,
different levels.
the market does come into play there. And there's a study that PTs like to cite all the time, and it's they gave an orthopedic test to a bunch of different clinicians. They gave it to orthopedic surgeons, doctors, physical therapists, all kinds of different practices. And they took the net score of who knew the most about orthopedic knowledge. And number one was orthopedic surgeons. Number two was orthopedic specialists in physical therapy, or an OCS. Then it was regular physical therapist. Then it was PT student. Then it was general practitioner physician.
Well, and again, because it's the specialist, right?
So it's one of those things where now it's when it purely in the orthopedic realm, a PT is as good, if not better, than your physician. That's the take home from that study. At least that's what PTs like to say. But the broader point that I'm trying to make is you don't have to go right to the highest person, the most expensive person being your doctor, to get the answers that you need for healthcare. There are other options available that are often cheaper in the long run.
Well, and you may not even be able to see that GP.
Right.
Or, primary care doctors are only gatekeepers.
Correct.
They're just supposed to see the flags, and then they're supposed to recommend outward and onward from them. That's the whole design of the healthcare. So if you have somebody that's in the realm out here, and again, I could see where a PT who deals with it 7 days a week, 5 days a week, 8 hours a day, obviously they are a bit of an expert in what it is that they're dealing with. So if they're dealing with all wrists or all legs or all joints, then they're going to be an expert in it, and that makes sense. It's just common sense.
Yep. And the good ones are smart enough to know when to refer. And most of the ones I talk to, we will let you know this is something we can't handle.
Well, I assume there's a liability involved. If you're not going to want to extend your area of expertise beyond what you want to be liable for.
Mm-hmm.
So again, if it's something that's more elevated to than what your area of expertise is, you would want to refer, because again, you're still doing it in the best interest of the patient.
And this is something that the American Physical Therapy Association has been working on for decades. They had their Vision 2020, planned for 15 years now. And they wanted by the year 2020 PTs to be credentialed and recognized by the public as qualified of experts as physicians. That's why they transitioned the physical therapy degree to a doctorate of physical therapy as opposed to a master's degree. That hasn't really caught on because insurance doesn't recognize it. Insurance, it's funny, is if you have a copay and PT is classified as a specialist and you have to pay as much to go see a neurologist as you do to see a PT, but they don't reimburse the same.
Probably not. Probably not.
Which is very frustrating because you got to see your PT way more often than you got to see your neurologist. So that $35 specialist copay a visit adds up a little quickly.
Well, and not only that, I would think that you're getting individualized care from that PT as opposed to the neurologist. It's just another folder he's picking up on the way in the door.
Mm-hmm.
I mean, literally, because again, they're the experts.
Right.
But the experts to me would be the ones that are doing all the hands-on.
We're spending to me, it comes down to time. It's the providers that spend the most time with their patients are the ones that you're going to get the best results. You have more time to listen, you have more time to hear, you have more time to understand people's concerns. I can't tell you how many times I work with people, 45 minutes to an hour session, one-on-one. I'm not seeing anybody else. I'm not jumping over to somebody in the other room. We got 45 minutes of my undivided attention. What are we doing here? And it's after 3 weeks, they'll say something subtle and you go, why didn't you tell me that day one? Why didn't you tell your doctor that? What, the whole left side of your body goes numb every now and again? Like, that's a big thing. This happened this week. But, and you stopped taking your blood pressure medications? Hey, that's something. I'm really glad you told me that, because guess what? I'm getting on the phone with your GP right now, and we need to have a conversation. So these are some things that the more time you spend with people, people will tell you what their healthcare problems are. It's not that hard to triage this. Is if you know what to listen to and you actually listen and you actually care, it's not that hard.
I would hope not.
But unfortunately, that's what medicine has taken away from us. Is the number one complaint I hear from the doctors I talk to is they just don't get to spend enough time with their patients. And that's
well, and unfortunately, the doctors that do spend the time it's hard to get in
Yeah.
because they're already booked solid. And they're the ones that are trying to put it on to their nurse practitioners and to the physician's assistant. So it's difficult to get in to see some of these doctors, or they're not taking new patients. I had my doctor who I credit with saving my life because of some incidences a while back. I actually had a client, and I recommend him to all of my clients. I had a client that actually texted me the one day and said, he's only taking people that are relatives of patients.
It's all who you know. All who you know. So the last main bullet point I wanted to hit, just to kind of explain to people, is I was hoping you could just take a quick minute and explain the difference between Medicare Advantage and Medicare Supplement to people, because this is something that is it really irks me when people think they're getting a supplement plan and they actually get an Advantage plan and they don't understand the differences of that. Advantage plans can be great, and there's a lot of good Advantage plans out there. But if you think you're getting one and you're getting the other by accident, that irritates me.
Well, we have to back it up a little bit more. Original Medicare was introduced to the public in 1965.
Which is also to say Medicare is older people, Medicaid is lower income, with exceptions.
Well, we're not going to, Medicaid's a whole different discussion.
Medicaid's a whole other. Medicare,
we'll start with Medicare. Medicare was introduced to the American public in 1965. The basics of original Medicare have not changed over the last 50 years. The only thing that has changed is there's more home health care and more preventative care that was covered. Medicare Advantage plans were introduced in the 90s. Medicare Advantage plans, by definition, have to cover at least what original Medicare covers, and that's what they do cover. They don't cover the supplement. A supplement is in addition to what the original Medicare health plan was. Medicare Advantage plans cover original Medicare, so they cover when you go to the doctor. They cover when you go to the hospital. But there's payments that need to be made. Under original Medicare, it's a $1,556 deductible. If you go into a rehab facility, it's $194.50 per day between days 21 through days 100. That's original Medicare. Well, Medicare supplements cover that gap, but the Advantage plan doesn't. The Advantage plan leaves all those expenses out there. So the Advantage plan does not cost you anything, right? Typically. So it's the same as original Medicare. So every time you go to use it, it's going to cost you. You're going to be paying up to that deductible. You're going to be paying that copay per day in the rehab facility. Under the Part B, again, original Medicare, there's a deductible, and then once the deductible is met, there's a 20% copay. Well, the Advantage plan only covers what original, that's all they are required. So you're going to pay that deductible, or in the form of copays. You're going to pay a full 20% up to a specific dollar amount.
So I think it's always important to remember, like, the term deductible is kind of thrown around. Deductible is the amount of money you're going to pay before
the plan kicks in. So typically, yes.
So if you go, oh man, this plan only cost me $100 a month, but there's a $10,000 deductible. That means you're going to have to pay at least $10,000, assuming you have enough medical expenses to meet that.
Well,
you could pay up to that.
Well, and that's where you have to know the plan.
Versus the max.
Typically,
it's a little in the weeds, but
because you're talking under 65 healthcare now.
Yeah.
We seg you back to under 65. On the under 65 healthcare through the marketplace, which is what you're alluding to, there can be large deductibles. However,
are there
typically
large deductibles on the Medicare Advantage plan?
No.
Oh, okay.
No. But on the under 65, with the large deductibles, there are also plans that are available, and those are the ones I tend to steer my clients toward, where there may be copays.
Mm-hmm.
Okay, so a copay is a set dollar amount that you can pay. So, for example, you may have a marketplace plan that has a $10,000 deductible, but you may be able to go to your primary care doctor once a quarter for a $30 copay. Well, you could go to the primary care doctor outside of your deductible. So there are plans available like that. And those are the ones I tend to steer people to. Why? Because if you have a sinus infection, where you need to see a doctor because you can't get the antibiotic without going to the doctor, I want you to be able to have the option to just pay a $30 copay, $50, whatever it is, go get that prescription without having to pay the full office visit, which could be a couple $100s. So there are, but again, we're back and forth between Medicare and under 65.
I didn't realize. I thought the Advantage plans did have higher deductibles. I
Advantage plans typically don't have. They may have a drug deductible, which may or may not come into play, depending on if it's not a tier 1 or a tier 2 drug. But typically, the Advantage plans no longer have deductible.
Okay.
Typically, they do not.
But more copays often.
Always
Always copays.
more copays.
So for example, like a straight Medicare versus a Medicare Advantage, if you were to come to physical therapy, you would pay, what's the deductible for Medicare? Is your $230?
Well, the deductible for original Medicare this year is $233.
So you would pay basically that $233, and then if you
Well, odds are you probably would have paid that before you
Right.
saw the physical therapist, because
plus the 20% of that Medicare is not going to cover. And this is where it gets so confusing, where it's what's this going to cost is just so not a straight answer. It is it's very difficult.
Well, but it's not even cost, because under original Medicare, you can go see any doctor that takes Medicare. Again, we're back to network.
Yeah.
That's the real restriction, because the Medicare Advantage plans will give you a top dollar amount that you'll pay. Typically this year, the smallest one was $34.50 and the highest one was about $6,000. So they're anywhere in the range, anywhere in between, but it's the network that comes into play. Original Medicare, if you have a supplement that goes with it, depending on your age, if you're just 65, odds are you're paying maybe $150, $175 a month. Well, but then the most you're paying out of pocket anymore is $233. The Advantage plan, you're not paying anything per month, but you find yourself in the hospital, you could pay $34.50 up to $6,000. So, you're always paying something. It's just a matter of if you're using it or not.
So I think my goal when I started this conversation was that, let's try and find like a couple of bullet points that people need to understand to make an informed decision to find their insurance. And I think the answer is it's almost impossible to do that. And they should really, I'm going to go back to my jungle analogy. It's like trying to pick the right plan for you that makes the most sense. It's just they're just walking through the forest with their eyes closed, hoping they're going the right direction. And then they'll get these surprises. They'll get these things coming out and then, I didn't realize, I didn't take into account this plan's not going to cover a rehab stay, or, and they'll get into this mess. So I think at the end of the day, I think to bring it home this is why we need people like you out there in the world that are pointing people in the right direction, saying, listen, because you spend a couple hours with these patients before you're kind of really pointing them in the right direction.
A typical Medicare 101 appointment is 2 hours. I always schedule
so
at
you
least
sit
2
there and
hours.
you say, okay, well, you're a diabetic, you have this, you have the X number of dollars a month that you can afford for this. You are going to be able to sit down with that person, hear all their needs, listen to what their concerns are, understand what budget they have, and make the best guess that you can as far as, okay, well, this will cover this will cover this, your medications won't be too expensive, you won't have as much out of pocket, you might get in trouble if this happens. You can at least help people understand the pitfalls and...
I point out the liabilities and the costs under different options is what it comes down to.
Mm-hmm.
And typically, I ask for a lot of that information ahead of time because I do homework even before they come in. I have papers where I can say, okay, if you were to take this particular plan, this is what your actual cost would be for your prescription. This is what it would cost to see the doctor. If you want the supplement, this is what your cost would be. This is the drug plan that we would recommend, so that when you walk out after those 2 hours, you know exactly what your costs are based, your projections based on what the current information that we have.
I like that you use the word cost. That was something I was going to mention too, is like there's cheap plans and there's expensive plans. And I don't like those terms. There's low cost, high cost. And I think that's an important distinction for people, is I think it's cheap doesn't mean less expensive, and cheap doesn't mean better, and expensive doesn't necessarily mean better, rather. And I think you understand of how to weigh the pros and cons for everybody.
Well, perfect example. A set of twins. They both turned 65 a year ago. I put her on the Medicare supplement because she wanted good health care. She wanted to make sure that she didn't have to worry about anything, and she didn't mind paying a premium because then she didn't have to worry about the cost down the line. Now her brother, on the other hand, he's always looking to make things less. He's wherever he can save a dime, he's saving a dime. So he wanted the Advantage plan. Well, and that's fine. They both looked at healthcare as different. However, she went through the whole year, didn't have any issues. He, however, had a heart attack in the middle of it. He was on a monitor that, with his Advantage plan, that didn't cost him any premium, was costing him $500 a month because it wasn't covered by his Advantage plan. And that was his cost. Now, once he got to his maximum out of pocket, and once he had it for 10 months, sure, it didn't cost him anything after that, but now we got a whole new year starting. So while he thought he was saving money, his health predicated that he needed to spend more with the less expensive plan. His costs were actually higher with the less expensive plan. So again, it comes down to your history, your health, and what your actual costs are going to be, which we don't know. We don't have a crystal ball. We have no idea what our healthcare is going to do.
But you can take some educated guesses.
Well, we can at least show you where the liabilities are with it. Absolutely.
Ginny, I think that's a good place to end on it. Thank you so much for your time. The name of your company again is Healthcare Help. We'll put some links in the description, get links to all the website and everything. Thank you so much.
Thank you, Aaron.
You're welcome.